Welcome back, and we were prior to the break talking about the nasty bug that's going around town, which is a bronchial infection and probably some form of upper respiratory. And like I said, whooping cough is one of those things that seems to make a resurgence later in life because of waxing immunity. And that might be what's happening. And if you do get a tetanus shot, probably pertussis should be added to that to help re-immunize you. But after you get over this, then maybe you don't need to. Good hand washing is very important to preventing of any type of viral infection. Sneezing. Do yourself a favor and your friends, if you happen to be outside and you do think you're getting sick and you're going to be in a public place, it might not be a bad idea to get an N95. That is, N as in Nancy, 95 mask that will prevent you from spreading a lot of infections around there. And be careful of the hand sanitizers. You know, I've talked a lot about the hand sanitizers. They are potentially dangerous to kill off the good bacteria on your skin and set you up for methicillin or spider bite bacteria. I call it spider bite bacteria. It's really methicillin resistant staph. You kill all the natural staph on your skin, and then you select for this resistant staph. And if you have any type of immunodeficiency at all, a little scratch in the skin could allow that bacteria to get underneath there, even through a hair follicle, and set up a serious infection. So I see it a lot in people that use hand sanitizers. Good to use just soap and water, but that's really about all you need. We have Chuck on the phone. Chuck.
Hi, Doc.
Hey.
This regarding last week's show. There was a study I read about today in JAMA in 2014, and it's regarding legalized medical marijuana. The study was done between 1999 and 2010, and it said all 13 states that had legalized medical marijuana saw a 25% reduction in deaths related to the overdose of legally prescribed opioids. And I just thought that reinforced what you said last week about the impact marijuana could have on reducing the dependence and the side effects of opioids. So anyway, I thought I'd share that with you.
Yeah, that's very good. Thank you.
I also have the crud, so I won't call Ray after the show.
Yeah, I lost that last part of that. On the speaker.
I got a touch of the flu too, so I won't be calling Ray after the show.
Got a bit of a flu too, so he won't be calling Ray after the show.
Okay, okay. No, it's very true. And as I learned even more about marijuana and some of the different strains, a patient sent me a lot of information that I haven't really had a chance to digest. But I'm hoping when the Grove does open up that they come in and tell us about all the things that they might have. But apparently it's not just this closet grow marijuana. I mean, they have strains, they have different levels of CCBs and THC, and so I need to get educated a lot on what this all is. But it's quite, you know, it's taking it from this so-called closet drug to something that could be actually very potentially curative for a lot of different illnesses and ailments. And I really applaud the states that have taken the risk in passing it. I still think it's a little draconian about it. I was looking at I had to sign a patient's marijuana form right before I came over here, and gandering through the thing. I mean, the 10 nanogram limit of marijuana in your urine upon testing that's a horrible number. I can pick up 20 nanograms in someone who smoked marijuana maybe within a week. So 10 nanograms might pick it up within 2 weeks, and that's not what we're trying to do. Under the influence of marijuana, and this is where I think we need to, we need to talk to our legislators, and we need to educate them that 10 nanogram limit is not really a representative of people's ability to function on marijuana. So, I mean, if I do the different testing that I can do to detect marijuana, the metabolites in your urine, and the 300 nanogram test is really that one that catches you if you've smoked probably within the last, I want to say, because you have to have a much higher limit. I mean, if you smoked within a very short period of time, you're going to get that 300 nanogram. 20 nanogram is the standard for detecting it if you've recently smoked, and 10 nanogram is half of that. So it doesn't take much to set that limit. Do you understand what I'm saying? It doesn't take much to reach 10 nanograms. It takes a lot to reach 300 nanograms. You could have smoked a month ago and it would not show up at the 300 nanogram limit. And if you smoked a month ago, 20 nanograms might be in your system. So that is very draconian. And so, and apparently a patient was telling me that, they'll drive around and run your tag, and if they see you make a wrong move when you're driving and your license plate, or you come up as a listed medical marijuana user, you could be in some deep trouble. And I think it's a matter of time. I think there's still a small number of people in this community that have cards, but as the pharmacies continue to pull their crap, and tell me it's crap what they're doing to patients, I'm encouraging more and more people to lean towards medical marijuana for pain med reduction. There's no limit to what I can prescribe you in opioids. The pharmacies are not going to fill what we prescribe as doctors, and they'll blame the DEA, and it's all a lie. And like I talked on the last show, if you really want to find out what's going on, you need to ask your pharmacist, where is this delay coming from? Try and pinpoint him down. I heard today, just as I was this afternoon, a patient went in to fill her Percocet prescription, and the town was supposedly out. All the pharmacies were out. How is that possible? In a town of 30,000 people, most of them seniors who take pain medication for a legitimate reason, why are they not stocking this in the pharmacies? What is the problem? Yeah, I know there's a drug abuse problem. I know there's a diversion problem. We all understand that there is, but why do they not put it in their pharmacy? And they'll just draw a blank. I mean, oh, well, we didn't order it, or we didn't get it in, or they'll blame a backlog on the manufacturer. I mean, there's no backlog on manufacturing. There's no backlog from the DEA. It's the pharmacy that doesn't want to raise their numbers above a threshold. Once they go above a threshold, or they increase the amount of medication they're prescribing, it opens the door for the DEA to come in and ask questions. But if they never go over a certain level, the DEA can never ask any questions. It's just the same way as if you drive perfectly down the street, never make a mistake on the speed limit, never forget to signal, never forget to obey every traffic law there is. No officer in the world can pull you over. He has to have probable cause, and this is basically what it is that's going on in the thing. If they never exceed a certain limit, a certain amount, the DEA can never come in and investigate and cause them all kinds of trouble. But who's suffering as a result of this? Ultimately, it's you, the patient, that's suffering because you can't get your prescription. So, you know what? I mean, legitimately, if there was another pharmacy in town, if you could buy groceries at a place that didn't have a pharmacy in there, and this is the way they were treating you, I think I might look to do business elsewhere. Maybe it's just a small number of people, but business is business, and I hope one day we can get to the bottom of this, because it wasn't like that years ago, a couple of years ago. And it all started after Walgreens got in trouble for not paying attention to what they were doing. They were just filling prescriptions indiscriminately, not asking questions. Now they ask too many questions and they don't fill prescriptions at all. So the pendulum has swung entirely the other way. And most of my patients that are on medical marijuana do point to the fact that it is and does help to alleviate their pain, and it does help to reduce their use of the opioid medication. And That is, in my book, a really good thing, because since there are limits on what these pharmacies are going to stock, it would behoove you not to be caught up in a pinch, as one patient did, then force people to go into withdrawals on medications. It just shouldn't be that way. But this is a small battle that we're having to fight right now. And for not everybody is on opioids, not everybody takes those pain medications, so it's still a small number of relative to the population that is causing the problems. So anyway, but thank you, Chuck, for that call and pointing out that those numbers are truly what I see in my practice, and I'm glad that there's a study that substantiates that, and anything that we can do to save a life and maybe prevent an opioid death is always a very, very good thing. So prior to, we're going to go to break in a few minutes, but prior to Ray calling and Chuck calling, I was talking a little bit about one of the things that came up today, which was blood pressure in the office, and talking about the difference in blood pressures. And I know I've talked about this on the show before, and it's come up numerous times. People get really excited when their blood pressure goes, if they check it in, it goes up to 160, 170, they feel like they're going to stroke or they're going to have some problems. So let's talk about acute increases in blood pressure. So if you normally run, most people will run 130, 140 on their top number. They might run 70 to 80 on their bottom number. What would it take for you to actually stroke out, meaning to go into where you actually lost function into your brain? For normal blood pressures in that range, if you were to go to 240, much higher than that, and really narrow off some of the blood vessels, then certainly you could occlude some of the vital tissue in your brain. So you would have to almost have 100 millimeter increase or more in the systolic to have a particular, what they call lacunar infarct, where you actually tighten the blood vessels down so much that you can't get any blood past them. Most of the strokes that we see today are what they call embolic strokes, which means a piece of blood clot or a piece of atherosclerosis travels up in an artery and actually shuts that artery off. That's a totally different phenomenon, and that is somewhat related to blood pressure, but not as much as a true hypertensive stroke. There are what they call hypertensive urgency and hypertensive crises, and when we come back from the break, we'll talk a little bit about those. Thank you for tuning in.